Thank you for the pre-discussion, and welcome to everybody to the CMDA Monthly Meeting. We're so happy you're here. And we're going to jump right in and start with our first speaker. And probably, Swati, you can go ahead and bring up your slides. I'll stop sharing. But our first speaker is Dr. Swati Gaur. She is an internist and geriatrician who is the medical director of New Horizons Nursing Facilities in Georgia. She is currently the treasurer for AMDA, the Society for Post-Acute and Long-Term Care Medicine. And she serves as the chair of AMDA's Infection Advisory Committee. It's an honor to have you with us today, Dr. Gaur. Thank you so much.
Thank you. It's always such a pleasure to come and talk to you guys. I've shared with you guys multiple times how much I love coming and, chatting with you guys. It's always a back and forth, a lot of brain trust here in Colorado. I'll just jump right in. The topic is boosters. I thought it would be old news by now, but we seem to be in the midst of it. So these are the questions that actually Leslie was kind enough to, she's the keep things together kind of girl. These are the questions that she had shared with us. So we're going to kind of delve into that, why are the boosters needed? But right before that, I think it's so important for us to put things in context. And, just sharing this MMWR, this is, in the current pace of things, slightly old. It's August 24th, which we are in October, early part of October. But as we can see, the point here is that look at the unvaccinated case. And I think, the point here is that the majority of work that is to be done in the vaccination of unvaccinated people. Now, with that as a backdrop, we will continue on, and thank you for this slide, Leslie. I think this was such an effective slide. I'm going to minimize myself, but I think you guys may have seen this slide in the past. This was presented, I believe, in the Colorado Medical Directors Association, or Leslie can later on clarify that. But this is Colorado, and if you see the blue line is the inpatient total, and compare that to the green line, which is vaccinated people, it's really compelling to see, that vaccines are still very effective. So why are the boosters needed, right? This is a study that actually CMDA and group had published some time ago. And I want us to focus on this last piece. This is the this is the neutralizing titer, which, we are now, there is a lot of thought coalescing around the fact that, neutralizing titer could be used as a surrogate marker for immunity because, it's measurable. And, we can talk about some real world studies, but I just wanted to show you this slide. And I think this is an important slide. So the left, the control group is actually the healthcare workers. The second box is the nursing home residents. And this is after full vaccination. And look at the difference in the immunity. These bars are the ones that we are focusing upon. And if you look at the neutralizing antibody titer for vaccinated residents versus the vaccinated healthcare workers, there's a significant difference between the two. And even with the prior infection, of course, with a prior infection, the neutralizing titers were higher, but they were therefore, vaccination of healthcare workers and mandates are so important. So this same group was actually looked at when we after 6 months, and this is a study paper that is published or about to be published soon. And essentially what this showed is 16% of the residents did not have detectable antibody titers 2 weeks after the second shot of the vaccine. Compared to that, after 6 months, 70% did not have detectable antibody titers. That's a pretty significant number. Out of the healthcare workers, 2% did not have detectable antibody titers at immunization, and in 6 months, 16% did not had no detectable antibody titer. So what we are seeing here is that the immunity is waning as measured by antibody.
Swati, I think there were some sound issues.
That is also, yes.
Swati, I think there were some sound issues just a moment ago. There's a comment in the chat box asking, I missed the comments on COVID recovered neutralizing antibodies.
Oh, okay. Sure. I can go back real quick and go over that slide. So what I was saying about COVID recovered antibodies is that while they are higher than just the vaccine and no COVID, the difference is still there. That difference between healthcare workers and residents is still continues to be maintained. That's what I was pointing to. All right. So this is the real world, right? And this is the Delta. And Qatar is most closely related. This is from ACIP, one of the ACIP hearings. On August 13th. Qatar is the most closely related with the United States, and that's because we used both Moderna and Pfizer vaccine. And basically, you could see the Pfizer and Moderna difference. So if you look at the symptomatic disease, the immunity against Pfizer is really goes down. The immunity against hospitalization and death, though, is 90 to 100%, and is well maintained. So it's important to remember. So this is the real world example. All right, so this is a slide from Sarah Oliver's slide deck with the recent ACIP hearing, and essentially what we start to see is this is July data, and these blue, green, and red lines are United States, and as you see that the incidence of hospitalizations, COVID-19 hospitalizations among vaccinated people is going up starting July. We start seeing that bump up. However, I want us to look at these gray lines over here. This is Israel. Israel actually came out and vaccinated, their big number of people all at the same time, very, very early on. And as you can see, and they are a few months ahead of us. And as you can see that the number of cases who were vaccinated in January, February, March, April, literally keep marching up. So what we are seeing is the farther back the vaccination was, the higher number of breakthrough cases they had seen. Again, these cases we presume are Delta variant because the spike that they saw in the summer of this year seems to be primarily Delta variant. So this is again real world data that is compelling. All right, so what was happening with healthcare workers? So these are the two studies that basically show vaccine effectiveness against infection, not severe disease and death. This is against infection in healthcare workers. And as we can see, there is that drop in VE as we are noticing in July, in these two studies as well. So, this is again, the same Israel data that is, in the bar forms. And this is 60 plus folks. And these white are the healthcare workers, the essential workers who were vaccinated in that early cohort. And as you can see, the number of infections breakthrough infections is higher depending on whoever is, how far back did you get vaccinated? All right. So this is the Israel study, which was actually presented in the work pack that happened on, in the FDA work pack on when they were looking at data on Pfizer vaccine. And essentially what it showed is once you gave the boosters, 12 days after booster, so this is 12 days after booster, your risk days, so this is again, real world data, no booster here, 12 days after booster, your chance of getting the disease goes down. The relative risk of goes down by 11-fold. So that is pretty compelling. Now, this was done in 60 plus years, patients who were 60 plus years. And that's why we saw where, in the work pack, when they had a question that was put forth, should everyone be recommended a booster shot? The answer that the committee decided was no, because, the data was really, done on, gathered on 60 plus. So we need to keep that perspective as well. This is pretty much the same. And this data was published in NEJM. And of course, the confirmed infection was 11, but look at the severe illness, about 20-fold decrease in the relative risk for severe illness. Okay, after that, there was that interesting ACIP hearing. If anyone had a chance to kind of hang out there. And then, of course, after that ACIP hearing, the CDC, the head of CDC actually came out and put an end to all that intrigue and confusion that was going on right after the ACIP hearing. And shortly after, so that was Friday 2 weeks ago. And shortly after that, I went and got my booster. That being said, it's important for us to understand who is eligible now. So Leslie, that was your second question. So we need to just pay attention to this. If you are a resident in long-term care, there is compelling evidence, there is compelling data that supports the ACIP to say you and if you got the Pfizer vaccine, you should get a booster shot. However, if you are a healthcare worker and you got the Pfizer vaccine, you may get the booster shot. So this is important for us to remember. Booster in healthcare workers is not a mandate. The primary series is. So we need to really clearly kind of understand that. I know that there are a lot of people who were just ready to go and get the boosters. I was one of them. What about mixing and matching? And I'm going to go quickly. Well, there is a study, there is a multi-center trial that is currently being done. And we don't have the results yet, is the answer. Safety and immunogenicity in heterologous versus homologous prime boost. However, in Lancet, there was a study published after their AstraZeneca vaccine. And what they did is this yellow one is the AstraZeneca circle. And these are neutralizing titers on the x-axis. The blue one, the red one is AstraZeneca plus, so the primary shot was AstraZeneca. Second one was Pfizer, the red one. So as you see, the neutralizing titers actually go up significantly compared to AstraZeneca. However, they are pretty comparable to the Pfizer. There is slightly higher use of Tylenol, slightly higher rates of side effects. So that is to be kept in mind, but they were all reasonable. There were no serious side effects that were directly related to the actual heterologous administration. What about Moderna and J&J? It's very important for us to remember that no matter how much we want to go and get our booster shot, if we have received our Moderna, it's advisable to just wait and see what FDA comes out with. As you may know, Moderna has submitted data on half dose as booster, 50 micrograms as booster shot, and that data is going to be reviewed on 14th and 15th of October. Also, J&J data is going to be reviewed as well. So I'm excited about that VRBPAC meeting. Hopefully it's not going to be as exciting as the ACIP meeting, the last one. But you never know. Safety of the third dose of Moderna and Pfizer vaccine. This is again the data that was published with 3 primary dose series because they were starting to get the data back. And thank you, Leslie, for that slide as well. And as you can see, the data is pretty comparable to the second shot and not significantly higher. So similar, basically, this is again neutralizing titer and kind of says the same thing, that it's very effective. Reactogenicity data, similar to the second dose for local reactogenicity, and for systemic, again, the same thing. I want us to really give a moment to this slide. I did talk, we were talking about this, I think, saying Leslie and I, and we were talking about, I was saying, while most of my residents are vaccinated with Moderna shots, there are some who are vaccinated by Pfizer, and we have already given them the vaccine as they keep coming up with 6 months. The interval is actually 6 months, not earlier. This is what I wanted to point to. And I said, with 22% percentage positivity rate in our community, I have yet to see a case that popped up we have not made a case since that first dose of vaccine, the first series of vaccination, we have not had a case. And, we started talking about what gives, right? But we are seeing cases, for example, in the Northeast with very low community percentage positivity. So what I'm trying to say is, this is a pandemic, size problem, and there is not a single approach to it. So we need to focus on PPE use, cohorting, infection control processes, and staffing. I had 2 facilities, as you can see, facility 1 and facility 2. Facility 2 actually had lesser number of residents. However, with staffing shortages, with cohorting, and I suspect that some non-compliance with PPE use, we ended up making more cases. And this data is from before the vaccines actually came about, obviously. So my point here is, it is a multi-pronged approach that we need to be able to take. So for example, currently we are using a 95 respirator and a face shield for everyone, regardless of vaccination status. And the reason for that is, in our community right now, we are sitting at 16% percentage positivity rate. This is one of the slides that was shown in the ACIP hearings, and this is the modeling that Dr. Slayton had done. And this basically shows that even if you give, this is the x-axis is the percentage of residents who have received the booster. The y-axis is staff vaccination coverage with, so that's staff vaccination coverage, and this is your resident vaccination after boosters. And as you can see, if your staff vaccination is low, even if your resident vaccination is 100%, you cannot eliminate the case. I mean, you are still sitting worse than here. So my point here is, it's really important to drive up this arm. in addition to driving down the booster as well. And this is the last slide that Dr. Slayton had again said that the magnitude of the boosters can help reduce the cases, but the magnitude really depends on the effectiveness and staff vaccination coverage. So I am going to actually stop there. No, wait. How do we prepare the boosters? Well, there is one more thing that I wanted to say is focus on influenza. In our community, we already have influenza. We have started giving influenza vaccines, high dose influenza vaccine. If your influenza vaccine is effective, which means high dose, different arms is going to be important. Otherwise you may not know which one they're reacting to. This is a list that I had created based on actually the site. Please look at the links that are available here. There is a booster checklist, very good booster checklist that is available on the AMDA website.
Just a second.
I'd like for you guys to really look at that and use it. In this, I think the most important thing is staffing logistics. If you are starting out, make sure we used a lot of staff that was had to do extra staff logistics to make sure that we are monitoring our residents well, because they do need monitoring for 15 minutes. And education of staff on anaphylaxis was important, because anaphylaxis can come in as, vomiting and hypotension, and may not just present with, my lips are swelling and I can't breathe. Vaccine reporting is important, and your pharmacist is going to be your partner there. So thank you. I'll take questions.
Thank you, Swati. As you probably saw in the chat box, it looks like Jenny Albertson is reminding everyone that in Colorado, our facilities are required to offer this booster shot or a booster clinic to our residents by October 25th. So if anyone has a quick question for Dr. Gaur, you can take just a moment for that. And will it be okay for us to send your slides out to all of our members?
Absolutely, it would be great.
Thank you. Thank you. And that's a great list that you have there. Just try to be practical.
I love that list. I think that's great. Thank you so much, Swati, for being here. We can't thank you enough.
Thank you.
Appreciate it. And if there are people who think of other questions, go ahead and email them to me, and I'll make sure that Dr. Gaur gets back to all of us with the response. If you like to, we can move on. Not hearing any questions at the moment. So we have announcements from CHCA, CDPHE, and CMDA. So why don't we go ahead and start with Jenny Albertson with CHCA. Thank you.
Hello, everybody. Thanks for having me again. Just a couple of quick notes on the tail of what Swati was saying. As far as outbreaks go currently, the data from CDPHE is showing that 60% of our 526 active SNF cases in outbreaks are staff, and 39% of the 437 ALF cases are staff. So that gives us a little bit of a snapshot into our pre-mandate world. I thought that was kind of interesting data, and it'll be very interesting to compare in another month. So we have a couple of updates from CHCA. I know that a lot of you are on the residential strike team calls and whatnot, so I'm not going to belabor the latest and greatest on the mandate and so forth. I'm sure you all have already explored the 90% possibility and how that may impact our facilities. We're kind of just in a wait and see mode, and it looks like they canceled the call this afternoon. So I guess maybe we'll wait till they make some announcements directly to the residential care facilities tomorrow. And we'll have to keep our mouths a little bit more shut than we normally do. So, so that's that. Just a quick reminder on reporting requirements. I know that did come up on last week's call. This is the current baseline in case you're not as in touch with your administrators and DONs about this. And I think sometimes medical directors need to be mindful of what is being asked of the facilities for reporting. So of course, POC testing results daily for unvaccinated people entering the facility. They're still doing EM resource weekly data entry. for everything but COVID vaccination now, which has now migrated to the COFI system. They will be reporting that on the 1st and the 15th, their COVID vaccination data, and that is publicly made available. The state is projecting to reduce that to a once a month as of January 2022, depending on our infection rates. And then we still have a monthly reporting to NHSN, which requires people to have a level 3 access, and that is a duplicative entry of vaccination data. So that's where facilities sit with reporting right now. CHCA happenings, we have a lot of education coming up. Essentials of Nursing Home Administration is October 26th to 28th. That is broad-based, truly a once over for those who are new to our state or newly licensed or just want a refresher. I'm very pleased to see some people enrolling in that. That'll be a pretty intensive 19 different sessions, 3-day seminar all day long. Also, likewise, we're offering assisted living administrator licensure course in early November. That's a 40-hour course. And then we've added a few ones that might be of interest to you. Making residents the leaders of their own communities is one that I'm helping social services and activities presenters bring forward in early November, November 9th. The idea behind that, of course, being to reinvigorate the resident ownership and sense of meaning in their lives at the facilities, but also to put them in the driver's seat and take staff a little bit off the hot seat in order to improve quality of life. We're offering a QAPI mini-series by discipline for environmental services, social services, activities, and infection prevention the first few weeks of November. That's for all of those of you who might be irritated with the lack of content presented by those disciplines or inspiration they bring to problem solving in QAPI meetings. So I'm hoping to improve that with these bite-sized trainings. They'll be live and then recorded for later distribution and ongoing training. And then our fall convention, of course, as you know, was canceled. And so we're presenting a reinvigorating your education series with the 8 top requested elements that we're going to be presented at fall convention. They'll be presented, recorded, and then made available through recorded purchase. We're increasing our collaboration with Telegen right now. I think that's been an interest also for you all. Our Telegen folks have now been brought into several of our committee meetings. They are now going to also bring their PASSAR arm into social services to talk about mental health needs and interpreting the PASSAR to better hone our approaches per resident with PASSAR assessment, using it as a tool instead of just paper compliance. Isn't that a revelation? So that's exciting. That's a new development. And we have a monthly meeting now with Telegen, Doug and I do. So that's lovely. It's bearing some really quick fruit. And then CDPHE, Chad's on the call after me, so he can speak to this too if he wants to, but I know we're jointly developing a code of conduct. I finally found the original draft from 2008. We will be revamping that and getting on the same page, and Chad and crew have graciously agreed to join our district meetings to have surveyors in direct civil conversation with administrators and DONs in our district meetings. So that's beginning in October as well. And then with CMDA, I'm hoping to continue to offer bite-sized training opportunities to you all, and then hopefully helping with your convention coming up. So my blog is still posting. If you want a subscription to it, you can absolutely do that, and it will flag you when I post something new. Sometimes it'll be of interest to you, sometimes it won't. And I categorize it by topic so that you don't have to go through wade through a lot of data. And soon we will be posting there for resource for your facilities, some workforce development outcomes that we've been developing with our subcommittees. So it's everything from a CNA and nurse aid training database by district. So here's how this particular program does enrollment. Here's how many seats are available, what kinds of tuition reimbursements available, those kinds of resources, all the way to how do you make your scheduling more friendly for childcare issues and transportation support. So it's all kinds of things. So we'll be putting that out via my blog as well, so you can spy on us and see how we're doing and let me know. And I think that's my summary.
Thank you so much. I didn't know you had a blog. I'll have to check it out. But thanks for letting us know about the latest data and the wonderful education that's coming up with CHCA. All right, Chad. Thank you, Jenny. Okay, Chad Fear is here with us with CDPHE. Go ahead, Chad.
All right, thank you. Yeah, so I don't want to belabor all of the conversations. We have had plenty of conversations about COVID and infection control and those kind of things. But I did want to mention at least this. I do know the strike team at CDPHE had made some calls last week to facilities, different provider types, and polled those facilities to see if they felt like there was going to be some staffing issues, anticipated staffing issues with the deadline for the first mandated vaccination for 9:30. And so we had 4 or 5, number could have been 5 or 6 facilities where they felt like the mandated vaccination may affect their ability to operate. And of those, one reported concern was from a nursing facility. Surprisingly so. We had heard some things out there in the few weeks approaching that deadline, that there were going to be some nursing homes with staffing issues because of the mandated vaccination, particularly in rural areas. Kind of the further west and the further east you got, the more concerned there seemed to be. So I called the facility that had the issue, reported issue, and they had an amazing turnout to a couple of clinics that they offered to their staff. And they found themselves approaching 90 or 92% vaccination at the last time that I had spoken to them. That would have been probably mid-morning on 9:30. So the one situation that we thought could be an issue seemed to have resolved itself. Now, I don't want to jinx us, certainly, because I don't know that we're out of the woods yet in terms of vaccinations and the effect it might have on staffing. But at least, I think we dodged perhaps a bullet. And if, others may have more updated information. This was October 1st that I had the update on that. So fingers crossed, certainly. As Jenny had mentioned, I think we have a number of joint education opportunities that will be coming up here in the near future. And we certainly look forward to participating and collaborating with education, not only for the community, but in turn being able to provide that same education to our surveyors. I think it's so important that we are all on the same page. We all subscribe to the same approach. Jenny had mentioned the code of conduct training that we'll be putting together, and I know that's dusting off an old document. We do at CDPHE follow the REACH philosophy, which is much in line with the code of conduct. But kind of the basic thing there is just be kind. And we'll look at different ways of being able to get that message across to both nursing home surveyors and nursing home staff in moving towards the future. We are working on also another get together, I'll call it. It's a discussion right now. We've had the issue of substance abuse in nursing home residents come to the forefront. We've had a number of folks ask for a sit down, ask for some dialogue around balancing safety and resident rights. And we certainly want to tackle this as a system, together, collaborating the community, CDPHE, CHCA, Leading Age, the Ombudsman's Office, and CMDA as well. And it's been a little bit of a difficult proposition, because once you start adding a few folks from all the assorted different parts and pieces of our worlds, that group grows significantly. And at least at first, we want to make sure that our discussions can be manageable, and then we'll reach out from there. So we have that coming later in the month. I think we need to make sure our date is not in conflict. Just one quick other thing, just to let the group know that we're still seeing concerns right now with abuse, infection control, citations for kitchen, resident rights, the quality of life, quality of care, including accidents and pressure wounds, and nurse staffing and sufficient staffing as it relates to, directly relates to the lack of care. So we're being as compassionate as we possibly can and understanding that folks do struggle with staffing, but in those situations where there are multiple instances of that directly affecting care, we're going to be asking for some plans of correction around that immediate jeopardy situations. We continue to see facility acquired stage 4 pressure wounds, issues around accident hazards, and serious medication errors. So I think that's what I've got for you today. And if you have any questions or want to put something in the chat, I'd be happy to address that.
Appreciate you, Chad. Thanks for those updates. And I know that the CDPHE remains available to help with staffing for buildings that are still worried about that and still struggling. Thank you for everything. And there is a great comment in the chat box about how the nursing home leadership makes a big difference in terms of vaccination and dealing with the staffing crisis. Well, we have another announcement before we move on to our final presentation with Dr. Greg Gahm. But Allison Villegas, our CMDA Vice President, is going to present our CMDA letter regarding COVID-19 vaccine exemptions.
Hi, everyone. So I'm going to share my screen. Is that okay, seeing if I share it with the... Okay. So we sent the letter out on mid-September, and it's just a letter that we drafted in partnership with the CDPHE, voicing our support for the vaccine mandate. And so we added at the end of it, here's the letter, obviously, if you want to read it. And then we did include 2 appendix, one talking about the contraindications, which we are in support of what the CDC is recommending as contraindications. And then also a second appendix for resources on discussing the vaccine importance with staff members. So we just wanted to let you guys know, because I do believe we sent this out in an email blast, but just as a nice follow-up with some of the conversation and presentation by Dr. Gaur and from Jenny, just kind of talking about the need to get the staff members vaccinated as well and why we support it. I wanted to make sure you guys all were aware of that. Any questions?
There are several people right here on today's call that helped sign that letter, so we appreciate our members being in support of it.
I have a question. Allison, can you tell us what the SAGE Award is at Optum?
Thanks, Dr. Gahm. It is like a award for clinical excellence. The Optum Oscar is what I call it.
Yeah, well, can you show us yours? Because we should all congratulate Allison, who won that this year at the national arena, and it is a really tough thing to get. So just congratulations from all of us.
Thanks, Dr. Gahm. Thanks, everyone. Couldn't do it without everybody on CMDA and in our space, obviously. That's a great place to work.
Well deserved. We're so glad you're one of us.
It's an incredible honor. Congratulations.
Well, for our final presentation today, we have Dr. Greg Gahm, who is the Corporate Medical Director for Vivid Senior Living and a past president of CMDA. He's going to be talking about our influenza update and basic review of statistics at our request. And Greg, I didn't know if you wanted to share your slides or would you like me to?
If I open it up, I can do it, and then that way we'll just share a screen, I guess, if that works for you.
Yes, of course.
Let's see, share screen. There we go. Okay. Let me just start this. Okay, so we are, let's see, there we go. We are going to weave together some statistics because Singh asked me to do that after some recent discussions in other places, and also try to find an interesting way to make influenza get ready for the season and do that together. So those of you that are really interested in statistics, while I get started, find a piece of paper, scratch paper, and a pen, because I will have some work for you to do along the way. Those that aren't interested, you can sign off or fall asleep, get lunch, whatever you want to do. Okay, so we're going to start out with basic statistics, and this goes way back for a lot of us. Again, it's the basic 2x2 box. You have the disease is either present or absent, so you assume that there's a gold standard that you can apply that would actually tell you if somebody had the disease, present or absent. And then there's the test that you're looking at, and the test can, in the simplest form of statistics, the test is either positive or negative. So really simple, if you have the disease and the test is positive, that is a true positive. If you have the disease, but the test is negative, that's a false negative. It should not have been negative. And then the same thing with false and true negatives. All right. Most people, when you start talking about statistics, live and die in sensitivity and specificity. And really, maybe that's as far as their interest went or goes. And it's not a terrible thing. It just only tells a small part of the story. So sensitivity is the proportion of the people who get a positive result in the test out of all those who actually have the condition. I should turn that off, sorry. Specificity is sort of the flip side of that. The number of people who got a negative test and they really don't have the disease. All right, so that's all well and good. And here are, I threw in the equations over here showing sensitivity and specificity. So again, true positives, if you divide that by everybody that has the disease, you get sensitivity. And the same thing here, true negatives divided by everybody that doesn't have the disease, you get specificity. Okay, and those are important characteristics of tests that, we do want to know that for tests. And just another quick comment, there's almost always a trade-off between sensitivity and specificity, so that when one goes up, the other goes down. If you need to identify everybody possible with a condition, you really want a high sensitivity. I mean, it doesn't matter if you have some negatives where they don't belong. You really want to catch everybody that's positive. On the other hand, if you really need to accurately identify people that don't have the condition, you want the specificity to be high. And it's one of those things, ideally, both of them are high. You want both of them to be 100%, but that just almost never happens. Then we come to the question that really brought around why we're doing this today. When we test someone, what do you really want to know? You don't really want to know the sensitivity or specificity. When you order a test, you want to know that if you get a positive result or a negative result, what are the chances that it's really positive or really negative? As in, can you trust it? So that becomes what's called the positive and negative predictive value. So the positive predictive value is a probability if you get a positive test that the people really have the disease. Or if you get a negative predictive value, if you get a negative, people really don't have the disease. So again, more equations, sorry. But again, back to the 2x2 table, here it is. So again, you get a positive result. So the positive predictive value is true positives. You're going to divide by everybody that got a positive test. And the same thing with the negative predictive value, take the true negatives and divide it by everybody that got a negative test. Okay, enough with the basics. Now we're going to actually do some calculations. And this is for those of you that are really interested in statistics and want to figure this out and see it work in action. I'm going to have you do some homework here in a minute. And in the background, you can multitask and listen to me talk about influenza. by the way, almost nothing I'm going to say wasn't in the update that I already sent out. So if you already poured through that, you're not going to miss anything. If you have your paper and pencil ready, you're going to want to write down some numbers that I'm going to give you here in just a second. And hopefully if you do the math yourself, like I told my kids when they're going through the math, you got to do a lot of problems because you got to cement seeing yourself get the answer. Okay, here we go. And by the way, even if you do them, we're going to circle back as a group and sort of show you how to do it anyway. So if you're not doing it, you won't miss out. Here's we're going to look at 2 different diseases. I want you to calculate the positive and negative predictive value for each one. For both tests, we're going to take some license and we're going to say that they're really good tests. They have a 95% sensitivity and a 96% specificity. So those are numbers you're going to want to write down if you're going to do the problem. And that's actually that is really good for most tests. We're going to apply this to 10,000 people. So we're going to go give this test to a whole population of 10,000 people. And then the difference between the 2 populations, 2 problems, for disease number 1, we know for a fact that the prevalence of the disease in this population we're testing of 10,000 people, the prevalence is 25% of the population. So 1 out of every 4 people has that disease. For disease number 2, I want you to do it all over again, but this time only 4% of the people. So 4 out of every 100 people, 1 out of every 25 actually have the disease. So those of you that want to do the math, you break off right here at this point and you start doing the math. You have all the tools. I've given you all the equations. You can go figure this out. The rest of us, let's go look at influenza for a few minutes. And I have, just to make this simple, I have 7 takeaways for this year. So we're just going to boil everything down to 7 quick things. And then obviously, if there are other questions, I'll be more than happy to field those. First question, when should we vaccinate? And again, remember, this is according to Dr. Gahm. This is not according to the CDC or anybody else. And I'll tell you why in a minute. For staff, yeah, now, anytime in the next 6 weeks, whenever when you're doing your booster clinic, you can give it with COVID anytime. Great, go get it done. For anybody that's on Part A stay, rehab, they're not going to be there, they're going to go home. Just make sure that they either got it in the hospital or you give them their flu vaccine before they discharge. You want to get them now. And then here's the part where I differ a little bit with CDC and others. Long-term care residents, long-term, I usually tell people mid-November to mid-December. The reason that differs from CDC is CDC doesn't break it down by site of residents. We have a captive audience. And as long as they're not going anywhere, we know that we can get them. In the community with geriatrics, if you see a patient in September, you may not see them again before January or February. And then you have to trust that they'll go out of their way to get a flu shot. You go ahead and give it to them while you got it. So while you have them captive, go ahead and give it. But for the long-term custodial care, I always recommend mid-November, mid-December. And the reason being, we've learned so much about immunology refreshers in the past 2 years, but we know when their antibodies are going to peak. We know how long they're going to last. The older and the sicker they are, the quicker they're going to go away, the less protected they're going to be. So trying to time your vaccination to when influenza is going to get here just becomes that much better. In a normal year, mid-January is the peak time when we start seeing influenza A, which is really the one that we're worried about, which is why this timing works. Now, 1 year out of every 6 or 7, we get influenza early. My favorite was back in 2006, I believe, when we had A Sydney, and it peaked here at Thanksgiving, got here really early. But one of the nice things about being in the Intermountain region in Colorado, influenza almost never starts here. I can't think of a single time it starts here. It starts in California, and Hawaii, and Alaska, Texas, Florida, New York, but it doesn't start in Colorado. So what I do is I go onto the CDC site and I track all those other places every week. As of last night, there are 0 influenza A in Texas. So we know, and it takes about, once I see it start to peaking in one of those peripheral states, it takes about 2 weeks to get here and start building up steam. So I watch that. And if this is that odd year that it's going to get here early, I'll put out an alert to everybody. Whoops, it's not going to wait till January, get it done now. Okay. Which vaccine should we use? And you already covered part of this. If you're under 65, just younger patients without an immunocompromising disease, you're going to use quadrivalent, which is the standard vaccine. If you're over 65 or you have an immunocompromising disease, you have your choice. You really want to use high dose or adjuvant vaccine. They're both equally effective. You can choose whichever one you get the best price for. It doesn't really matter. Here's my favorite question. Is this going to be a bad year? And just the answer is, who knows? Here's the reasons it should be a bad year. Both of the A strains in the vaccine are new. A is the one we worry about. There was almost no flu last year. Means there's almost no herd immunity. Vaccine hesitancy with COVID, I'm already seeing having unintended consequences for the number of people wanting to be vaccinated against influenza, including staff. And I think this is going to be a significant problem in the next couple of months. Staff are going to say, so what if I don't get vaccinated for flu? I've decided I don't like vaccines. And what's the punishment? Well, we have to wear a mask. So what? Have to wear a mask anyway. So that's the reason it could be a bad year. The other side says it's not going to be a bad year. We're still social distancing. We're wearing masks. And thanks to all those unvaccinated people with COVID, we still have a lot of COVID out there. So there should be plenty of COVID. And throughout the season, that means people will have non-specific increase in viral interferon, blocking respiratory infections. Interferon is a protein that your liver makes. When you get any viral respiratory infection, you increase making that for 2, 3, 4 days, and it really just inhibits all respiratory viruses from attaching along your respiratory tract. So that would tell you that, no, it's not going to be a bad year. But then again, surgical masks, while they work really well against COVID, don't do a thing for influenza. And they're not, it's because they're not aerosolized like COVID, they're airborne. So it goes right through the mask like water through a screen door, and they spread through the ventilation system because they're not primarily attached to water vapor that's going to fall to the ground. So I have no idea. It's going to be a bad year. Get the vaccine anyway. Quadrivalent high dose, I get this question every year, and it's confusing because both of them have a 4 in them. Quadrivalent is 4 virus strains, an H2N, an A, H2N2, H3N2, an A, H1N1, and 2 different Bs, Yamagata and Victoria. So it's just got 4 strains. High dose, you use 4 times as much antigen of each of those 4, but you don't, but it's not, yeah, anyway, it's 4 times as much. So high dose goes to older people, quadrivalent goes to younger people. There's the difference. All right, simple questions now to wrap up. Is egg allergy a contraindication? No, we got rid of that in 2011, 2012. ACIP came out and said, it just doesn't happen. It's not any higher with influenza than any other vaccine, and it's not very high with influenza. Can flu be given at the same time as COVID, as the vaccine or the booster? The answer is yes. You heard it said you can give it both arms. You actually, that's just so you can tell where the side effects are coming from. It doesn't affect the immunity. There are 2 different vaccines in research right now. One that would combine COVID and influenza into a single dose vaccine, and one that does those 2 and RSV. And I think those will be available perhaps by next year. So that would tell you we're going to give it the same place anyway. This one's really important, number 7. Refrigerate it until it gets into the arm. Once the vaccine warms up to room temperature, which takes only 3, 4, 5 minutes, it'll be inert. It's just giving them saline. And you don't want to just give saline. There is a reason that we keep these things vaccinated. So with staff, take them to the vaccine refrigerator. With residents, use coolers, take them 2 or 3 or 4 at a time, but not all at once, but vaccinate quickly after taking them out of the fridge. Okay, we'll come back and see if there's questions at the end. Back to our problem. For those of you in the math team, hope you're done with your numbers, because here we go. If we use the gold standard, we knew with the first disease, we had 2,500 people that had disease, 7,500 did not. 95% sensitivity tells us that we have 2,375 true positives. We have 125, doing the math, false negatives. Here we go, 96% specificity gives us 7,200 true negatives and 300 false positives. Okay, so there were a total then of 2,675 positive tests, 7,325 negative tests. So the positive predictive value is the 2,375 true positives divided by the 2,675, the number of positives. So we have an 88.7% positive predictive value. So if you get a positive with this test, almost 90% of the time, it really is going to be positive. 10% of the time, it's not. Negative, flip side of that, negative was really good here. If you do the negative predictive value, just over 98% of the time, if you get a negative, it really is going to be negative. All right, so what you would take away from that again is about 10 times, about 1 time in 12, that positive test really isn't positive. So if the consequences are high, you have to think about it. All right, now we go to a disease that only has a 4% prevalence in the community. So again, using our gold standard, we have 400 people with the disease and 9,600 who don't have it. So out of that, we get 380 true positives, 20 false negatives, 9,216 true negatives, 384 false positives. Oops. So 764 positives, 9,436 negatives. But look at this. Our positive predictive value ends up, because we have 380 true positives, but 384 false positives, is basically 50-50. You know, if you get a positive, flip a coin to decide whether they have the disease or not. And negative predictive value, again, turns out to be a really good test. So the main lesson for this basic review is figure out why you're doing a test, what you want to get out of it. But remember that the prevalence of the disease in the population being tested has an enormous impact on how you interpret the test result. And with that, I'll turn it back over to you, Sing. I'll just open it up for questions. Because we're right at, oh good, 1 minute to go.
Thank you. Thank you so much. You're a wonderful teacher. And how do you apply those issues with the sensitivity and specificity to your COVID testing in your buildings? And do you use the prevalence then of the general community, or kind of look at a prevalence within a facility?
Yeah, those are good questions. I think it's really hard to figure out the prevalence. It's a moving target in a given community. The facility is too small, really, to be on top of that all the time. I mean, you could figure it out week to week, especially since we do good PCR testing in the weeks we do it on everybody. We can figure that out. I think it's more valuable for us to think of it in terms of the community. So one of the problems, again, that we had last year, we had tests that, given the test characteristics, the sensitivity and specificity we were given for those tests, or we could calculate on our own, we ended up with some tests that had positive predictive value of 18 to 20%, even 30%. And to me, that was scary, that if you get a positive, it's only really positive 1 time out of 5, 1 out of 3. So almost all the time that we get a positive, and I tell the patient it's positive, it really isn't. That's a problem. And it wasn't, I was asked this question, it came up with curative and other things. So did patients die? And the answer is no. We identified way too many patients, and we may have seen some false negatives here, which is why the FDA eventually took away the EUA for that test, because they found too many false negatives. We didn't see that as a huge problem here, but we saw a lot of false positives. So what's wrong with the false positive? With that test, every time you got a positive, it required an infection control survey. And every time you had an infection control survey was an opportunity for, doing the right thing. Say it would come in and survey and find a mask under a nose, or find hands not being washed enough, or find people wandering around doing things that were wrong. And that's an opportunity for a fine, which may or may not be appropriate. I'm not here to decide that. But if the test that we were basing it on was wrong 75 to 80% of the time, that's an opportunity to find people that shouldn't have happened. It was also an opportunity to lose 2 weeks of admitting patients, 3/4 of the time. So it really was a financial hit to facilities at a time when census was down, revenue was down, and expenses were sky high. And that's why doing this stuff and knowing how to do it and how to interpret it really makes a difference. Because even though we did this a year ago, the opportunity to do this again will happen.
Very good. Thank you for giving us your take on it. I know it's always hard when the CDC is saying one thing and sometimes our state is asking us another.
Yeah.
In terms of testing. If there are any other questions, please feel free to ask them now, and feel free to go ahead and email us the questions. I know it's already 1:02, and so we can make sure you get your answers. Looks like Dr. Weaver has a question. What is the rationale to not include COVID recovered patients in data at facilities and only immunization rates?
Yeah, I don't know. All I've heard is that it's too hard to accurately track people that are really naturally immunized. There is limited data to show that disease plus vaccine is better than disease alone for immunity. But it's right there in the ballpark of sort of the booster data. We know it's better, but it's not like it's saving lives right, left. It's somewhat better. The big gap is between disease and vaccination and unvaccinated. They're the ones that really are driving the pandemic still. That's where the risk lies. But at least in talking with folks about should we count natural immunity, it was just too difficult to try to monitor. Not a good way to do it or trust it. And what do you do with a bad test? We just talked about it. What if the test only had a predictive value of 25%, positive predictive value, and you got a positive? Are you naturally immunized or not? Well, there's a 75% chance you're not. So when you use bad tests, it's hard to make decisions going forward based on that. So they landed on vaccine only, which makes sense.
Yeah, I was just going to chime in. Thank you so much, Greg. Some of the tests for finding out if you have antibodies, again, are so inaccurate, less than 50% accurate, that it would be really hard to make a decision based on that test. So I think that when we throw that into the mix, it's really hard to understand who is protected and who isn't.
Yeah, and I want to know, Renee, if I made a mistake, just tell me. I don't mind making mistakes. Where did I make my mistake?
Sorry, I really did not mean that to go to the group. I just wanted you to know for future reference. So I think for negative predictive value, instead of having true negatives in the numerator, you accidentally had false negatives in the numerator.
Well, that's not good. That's not good. So see, you picked it up. You won the bonus prize. So I will correct that.
I'm a stats geek myself, and I love this stuff. So,
well, thank you. And
yeah, great presentation.
I'm humble enough to. I don't mind being called out in public either. That's a fine thing.
Well, if there are any other questions or comments, please go ahead and say them now. And otherwise, go ahead and email them to us and we can make sure you get your answers. CMDA will be happy to share the slides for both the presentations today. Thank you for joining us.
Thank you.